Good evening, everyone. My name is Evelien Dekker. I'm a gastroenterologist in Amsterdam at the Amsterdam University Medical Centers, and I'm very happy to chair this webinar tonight. The webinar is a collaboration between ESGE and GI Supply. And the topic is lifting polyps and then the importance of submucosal lifting agents. But we will cover all kinds of topics around that. For the fourth consecutive year, ESGE offers you the opportunity to view high-quality presentations on hot endoscopy topics from world leaders in endoscopy, and to interact also with the speakers and to participate by submitting online questions. So please don't forget to do that, because we like to have discussions with you. This is the program. The agenda for tonight will be that I start with discussing with you the endoscopic assessments of polyps and resection strategy. Then Professor Hassan from Italy will discuss with you the safety and efficacy of endoscopic resections. And then Professor Rex from Indiana, from the United States, will discuss lifting agents in EMR, tips on conventional EMR, and the specific topic of EverLift EMRs. And of course, we hope to finish again with some questions and answers with you. So I will head off today, and the topic for me is the endoscopic assessment of polyps that might help you to target your or to plan your resection strategy. I have some disclosures to make, as you can see in this slide. In the past years, a large evolution has happened in endoscopy, whereas the surgeons have moved from invasive surgery, open surgery, to laparoscopy, and now even endoscopic surgery. We have moved the other way around. We have moved from diagnostic endoscopy to more and more therapeutic endoscopy, and now I would say we perform endoscopic surgery as well. So we are meeting as others, as surgeons and endoscopists. So EMR is the gold standard for large benign polyps, as you know, but there's also some disadvantages about endoscopic mucosal resection. The advantages are that it's a safe procedure with very few emergency surgeries, especially when in expert hands. It's an efficient technique to remove benign polyps with a technical and a clinical success of over 92%. It's relatively cheap. It's quick and relatively easy, and the size of those benign lesions can be rather unlimited. It's more the location that might limit you a little bit. On the other hand, the disadvantages are the recurrence risk, 16 up to 30%, meaning that at least you should do surveillance once or twice after your piecemeal EMR. There's a risk of delayed bleeding, 6% at most. But importantly, there's also a risk that in such a lesion, you run into an unexpected malignancy. And then the problem is you have inadequate histology. And that means that when there is submucosal invasion, generally, you will not be able to judge whether the patient has been cured from the early cancer. And T1 cancers is an issue at the moment. Incidence is rising due to the screening programs, and up to 40% of all screen-detected cancers currently, for example, in our country, in the Netherlands, are T1 cancers. That means a real potential for endoscopic cure, because the risk of lymph node metastasis of those T1 cancers overall is just 8%. And those will need extra therapy, but the others will not. So today practice that the problem is that there's suboptimal recognition of the T1 cancers. We know that from our screening program in the Netherlands again, that although I think our endoscopists are well trained and well skilled, we misdiagnose those early cancers very often as benign. Besides, there's inadequate resection because those will then be removed, for example, by piecemeal EMR. And on the other hand, there's overuse of surgery in correctly recognized cancers because the option of endoscopic therapy has not been considered. So the issue between benign, early, maybe covert cancer and deeply invasive cancers are that there is a risk of undertreatment, which means that we do not want to miss early cancer and have inappropriate histology, but also we do not wish to endoscopically resect deeply invasive cancers because that also has adherent risks. On the other hand, there's the risk of overtreatment because we do not wish to perform morbid surgery when endoscopic therapy is still possible. So when is a T1 cancer adequately removed and the patient cured? Well, that means that first of all, an en bloc resection is necessary because we need to be able to assess the lesion. And it should be radical. So that means that both the vertical as well as the horizontal margins should be free from cancer. Besides, there's a debate about submucosal invasion depth. I will discuss that in a minute. But for sure, high-risk features are lymphovascular invasion, poor tumor differentiation, and tumor budding. So how about submucosal invasion? We've recently performed a meta-analysis of all the patients in 8 studies, so overall covering over 3,500 patients. And what we saw is that the absolute risk for lymph node metastasis, if deep invasion is the only risk factor that's present, is only 2.6%. And as you can see here, the overall odds ratio is 1.73%. So that's not really significant. And if you compare that to the other risk factors, tumor budding on the left lower hand with 2.8 and the lymphovascular invasion are the strongest predictors for lymph node metastasis. So this puts the risk factors a bit into perspective. And decision-making in T1 cancer treatment, therefore, I think is very clear. We need high quality histology because we need exactly all those aspects from our pathologists. So how do we get appropriate histology for the pathologist to help us here, to guide us here? Well, ESD is definitely the way to go then. It provides you with good histology, low recurrence rates because it's a radical resection en bloc. There's a potential cure for low-risk T1 cancers, and the size may be unlimited. Of course, though, that takes expertise and as well as extra time. So on the other hand, the disadvantages are the time, resource, and resource-consuming aspects of the ESD, the high technical aspects demanding experts for that, high costs, higher complication rates, and it's non-curative in case of deep invasion. Well, what is deep? Deeper than SM3 then, I think, or high-risk features. EFTR is another option, that the idea is that we make a perforation by cutting the whole lesion through all the layers of the bowel, but before doing so, we already close the perforation, as you can see in the schematic drawing on the left hand. It provides you with optimal histology. It's a safe transmural resection. It's easy and quick. There's R0 possibility in non-lifting cases or difficult location, and also in deeper SM invasion, it provides you with a good diagnostic biopsy. However, this can only be done in relatively small lesions, so lesions smaller than 2 centimeters. Besides, in the very distal rectum, it's not the place to do it because it's very difficult to pull the whole lesion into your cap. It's a relatively costly procedure. There's a risk of delayed perforation, and we have no long-term data yet, but of course they are being collected currently. So when we look at all those curative options and all the risk factors as we just discussed, I think it becomes definitely clear that we need to recognize endoscopically those early cancers because we need to plan which kind of procedure we are going to perform. And that here is the example of the accurate optical diagnosis. So every time I would like to promote it for any polyp you see, small or large, anywhere in the colon, you always structurally assess that polyp, its location, size, morphology, and the surface. So how can we do that? Well, we use our high definition endoscopes. Then we always use our option of virtual chroma endoscopy. That's actually on almost every endoscope now. And then we use our classification systems, the CUDO, the NICE, the WASP, And then if there is a potential of submucosal invasion, the JNET or the Sano or the Hiroshima. And lastly, of course, AI is one of the possibilities that might help you in assessing the polyp. This is the well-known NICE classification. I won't go into detail, but it differentiates on the left hand the hyperplastic lesions, in the middle the adenoma. And when you see the pattern with MBI in this case on the right hand, you see a deeply invasive cancer that's generally not amenable for endoscopic resection. So when we are in doubt about the potential invasiveness of a lesion, the JNET should be used. It's described by our Japanese colleagues that are really experts in assessing the mucosal pattern. And type 2A and 2B is exactly where we should be to still make a radical resection. And type 2B means probably early invasive cancer or potentially only high-grade dysplasia. So again, we can resect that endoscopically. However, the Japanese usually do that with their magnifying chromo, in this case with Cressil Violet, and also with their magnification. So that's a bit different usually from how it is done in the Western world, but I think we can definitely learn from our Japanese colleagues in this sense. However, JNET is good, but neither perfect. So the positive predictive value of type 2A, which is just low-grade dysplasia, is 98%. But look at the positive predictive value for 2B. That's only 51%. So it's still difficult to really assess that well. So I think in case of doubt, we should make sure we do an en bloc resection that would be good enough for early invasive cancer. Could we have help from AI in this sense in trying to diagnose better early cancers? There's many AI systems on the market. This is from a recent publication from Ralph Bishops and his group, the different systems available, both for detection as well as differentiation of lesions in the colon and also in the esophagus. And this is just one example of a system that helps you both detecting as well as in differentiation of the lesions between just NICE 1 and 2, so NICE hyperplastic or adenoma. So how about the early cancers? Well, maybe we can be helped by computers there as well, but probably this is also going to be more difficult. This was an early study. Few studies have been performed so far, but in these cases, actually, the system was as good as experts and better than trainees. So I definitely think there is a way forward there as well. So how about the covert cancers? Well, there's one issue that you should be aware of, and that's that the risk of cancer also differs not just by the pit pattern, but also by the location and the LST classification. And that's why I said you should always structurally assess all the lesions. And you can see here clearly in this lower end in the rectum, when you detect a lesion that's non-granular, the risk of submucosal invasion is 15%. Well, whereas this case in the right-sided colon, it's only 4.2%. And when the lesion is granular in the right-sided colon, the submucosal invasion risk is only 0.8%. So this also should guide you a little bit in planning your resection strategy. The same was shown more recently by the Italian group. They showed exactly the same type of results, showing that the lesions that are granular, once they have a specific nodule, that is provides you with the highest risk of submucosal invasion, especially in the left-sided colon, in the rectum again. And you can see here the risk in the rectum of such a one nodule is 22.1% when in the rectum, whereas in the right-sided colon or anywhere else, the risk is only 5%. So I would like to conclude that piecemeal EMR is the gold standard and is a good technique for almost all large colorectal polyps probably over 90%, because there's relatively little risk of being a cancer and and it therefore is an appropriate technique. However, when there's any suspicion of submucosal invasion, en bloc resection is key. And rectal location means that there's a high risk for such an unexpected cancer. So I think the threshold for an en bloc resection, or so for example, ESD or EFTR, should be very low when the lesion is located in the rectum. Deep submucosal invasion does not seem to be an independent risk factor for lymph node metastasis. So even an SM3 without any other risk factor might be still appropriately treated with local resection. And lastly, EFTR, as I've shown you, is a promising new tool for a safe excisional biopsy, also when deeper submucosal invasion is suspected, but we need long-term data for that. So I thank you very much, and I would like to give the word to Professor Hassan.
Thanks, Evelien. Very nice presentation. Only one question, and then I move to the second talk. You can predict submucosal invasion based on location and morphology. So why do you need optical biopsy? I have a lesion in the rectum, and I know that there is a high risk of submucosal invasion. On the other hand, I have a lesion in the proximal colon that is homogeneous granular, no risk of submucosal invasion. Why optical biopsy? How you match the Sydney criteria with the optical biopsy by the Japanese expert?
Yeah, I tend to agree with you, Cesare. However, I think you have to be aware you don't try to resect a deeply submucosal invasive lesion, so a T2, I must say. I think there is still a contraindication to that endoscopically. And on the other hand, I think you're quite right. I've shown you, I think at the moment, we resect all rectal lesions, unless it's really granular and totally looking benign, we resect them en bloc with whatever technique is necessary for that because of the risk. And when higher up, we generally do not tend to do that because the risk is so low of being invasive unless you clearly see the invasive cancer already. So I don't dare to tell you that we can skip it, but I do agree with you that the other part of the structural assessment of the polyps might be very helpful as well, and maybe more helpful.
Okay, Evelien, so probably we can jump to the second talk, because then there are a lot of terrific videos by Doug. So you explained to us, Evelien, how we standardize the technique for a naive lesion. Unfortunately, all of this is not present when we deal with recurrence. Every patient is different, every technique is different, every endoscopy does it differently. So let's look not only at endoscopy, but how should we manage these patients. So first, we need to be aware that the recurrence, of course, can happen, that it can be very nasty, but we can predict the risk of recurrence. This comes from the Australian experience, where there are three big predictors of future recurrence. First, it is the size. I don't feel that the size is for the size, but the size means also a difficult access. It means that it may be over a fold, etc., or there may be some fibrosis. So first, size. Second, interprocedural bleeding. This means that we need to be extremely cautious when we cut, that we don't create bleeding. If we create bleeding, we need to treat in order to look at mucosal bridges and to prevent recurrence. But what really makes me crazy is the third, the high-grade dysplasia, because this suggests that also the natural history of the disease affect the risk of recurrence. And we are not happy, because the recurrence you don't want to have is the recurrence with the high-grade dysplasia. But this also tells you that if a high-grade dysplasia comes after an EMR, it's better to call this patient earlier than later. Secondly, we need to prevent. I guess that Doug has very nice video, so I will go quite quickly. After you do an EMR, you can do some thermal ablation on the margin of the defect. It may be tip snare coagulation, it may be APC. I really want to thank Peter because he did this meta-analysis that clearly show that whatever you do reduce substantially the risk of recurrence. But I also like this approach by the Mike Burke group because they emphasize that it is true. Whenever you do it, you get risk reduction. But the absolute gaining also depends from the pre-procedure risk. For instance, if you do piecemeal, a very big lesion with the tip snare coagulation, you go down from 24 to 5. Okay, big gain, so it is worth. But if the lesion is small, you go down only from 11 to 6%. So the gain here is much less. So the gain of the thermal ablation is related also with the initial risk. But there is also an organizational issue in recurrence that is probably neglected in our literature. The problem is that we do procedure, we know that there may be recurrence, we recommend surveillance to our patient, and what happens? Our patient do not come back to us. This is a very famous German experience showing that 40% of patients were lost at follow-up. Of course, they probably go to other centers to do the surveillance, but anyway, there is some disruption in the standardized process to identify and to treat recurrence. And these are the other causes on which we come back. But this is the experience in the Medlick Center in Indiana, and this is really a real life experience throughout several years. And you may see that the percentage of lost to follow-up is very similar to the German experience. So at the first follow-up, 27% of the patient did not come back to this center. Probably they went to another center, but again, this is somewhat a rupture of the follow-up process. And then after patient came back and they had the first recurrence, in 30%, they didn't come back in order to see whether they had a second recurrence. And this continued up to the fourth surveillance that is the core of this paper. But let's imagine that our patient come back. What is extremely important is that if there is a recurrence, we detect. If not, it is catastrophic error. And when we move back to this German experience, the scar of the EMR was not identified in 8.3%. And this led international group to do Delphi on how to avoid the possibility that the scar are not identified at surveillance. And Evelien Dekker was in, and we recommended that a tattoo should be placed for a polyp 20 millimeter or larger, resected in piecemeal with additional predictor of recurrence. And we also clarified that the tattoo must be injected on the opposite side as the lesion in order not to prevent the treatment of the next recurrence. But what is probably new is the fact that we can use advanced imaging, as Evelien clearly showed to us, to inspect the possible recurrence. This is very nice paper showing that when we pass from white light in high definition to a blue light, in this case NBI, the sensitivity increases from an unsatisfactory 67% to an outstanding 93%. And these are two examples from this paper. You can see that the recurrence has the same characteristic as Evelien was mentioning, that is the Kudo pit pattern, while the morphology can be slightly elevated or completely flat. This is very clear in blue light. This is not so clear in white light. And this was confirmed by another group led by Mike Wallace, showing that not only you need the blue light, but you also need the magnification, that in this case it was the near focus by Olympus, and you get to an outstanding negative predictive value of 100%. And these are two examples, one from this paper, one from Doug paper. And I want you to vote and to tell me if on any of these picture you see a recurrence. David, can you activate the polling? Okay, both A and B are recurrence. A is recurrence, but B not. B is a recurrence, but A not. 36%. So thanks so much, Dave. Just focus on B, because it is somewhat an historic picture, because it comes directly from this landmark paper in 2015 by Doug, showing that not all protrusions that are on a EMR scar are necessarily neoplastic. They can just be artifact due to the clipping that is more and more frequent. You will hear from Doug. What makes the different, please follow the thin arrow, is the fact that the pit pattern is not the Kudo 3, 4, and this makes the difference in between a clip artifact and a recurrence. Should we biopsy? Should we not biopsy? So what we recommend as ESGE, and then maybe we are curious to know what Doug thinks, is that if you have all of this advanced imaging, that is blue light and possible magnification, you are completely certain. When I say completely certain, I mean with high confidence that there is no recurrence. You don't need to do a biopsy. But if you don't have this advanced imaging, if your level of confidence is low, please do a biopsy. What is probably fascinating about recurrence is the treatment, but it is absolutely not codified. So you have a lot of options, and again, we will see some in the next video by Doug. You can precut, inject, flush, suck, snare, avulse, burn, and you must be flexible in doing all of this. This is from the recent experience by Doug, and you can see how he used whatever he had to remove this recurrent neoplastic tissue. It may be hot snaring, hot forceps avulsion, ablation. You can repeat the EMR. You can retreat the border with APC, etc. So you must be flexible. This is the message. Don't think to have a standardized approach for recurrence. You must be flexible. This is a recurrence that we had in our center, a patient that came on ulcerative colitis after EMR recurrence, treated several times. And what we did was to initiate the treatment by doing a pre-cut. And this is because the pre-cut allows you to position the snare deep in the submucosal. Of course, first we excluded that there was a deep invasion, and then we lifted the border because the center, of course, had the non-lifting appearance. And then after we did this dynamic injection, we did this pre-cut. We find this extremely useful when you deal with the recurrence, because you delineate very well the border, you know where to put the snare, and you can approach a bit more aggressively the central part of the lesion. We use a lot the underwater approach, even if we inject, because here any millimeter you gain may make the difference between a good and bad procedure. And then, of course, we do a piecemeal. But this part is somewhat easy to standardize. This is much more difficult, and this is when you get the fibrosis, and we learned this technique directly by Doug, that you can suck the lesion into the cap, and you somewhat suck the lesion in the snare, and then you cut the lesion with the cold biopsy snare. We found this technique extremely effective for the recurrence, and basically we always use this approach now in our center. And you will see now the end of the treatment that was extremely satisfactory, and the patient was cured. But you must be aware that the recurrence may be extremely nasty. I don't know if Evelyn and Doug agree. Maybe the recurrence may be the only benign lesion that sometimes the endoscopist cannot remove. This is again a person that was referred to us after several attempts. We also did several attempts, and it just came back 10 days ago, and we had this circumferential recurrence on the EMR that was extremely long, probably more than 10 centimeters up the anus. And of course, we tried with all we said before, that is to use the snare, to use the water, to suck in the cap, and then to try to cut. But despite all of this activity in more than one session, because you should not be ashamed to recall the patient after 2-3 times. Here we found some tissue that was somewhat removable. And we cut whatever we could cut. Here we did the pre-cut in order to allow this nerve to go in. And the maneuver was partially effective. And then you may see that you cannot even, you cannot take very deeply the lesion. So the cuts are not fully effective. And at the end, we simply decide to abandon the treatment, because there was too much tissue, and there was no reasonable approach to it. Of course, the decision whether to send to surgery depends also on the comorbidity of the patient. This is again from the Indian experience. You may see that 3% eventually proceed to surgery, and even more importantly, 1% of them presented at recurrence with invasive cancer. This is to show that a good way to reduce recurrence is to use ESD, because as Evelyn anticipated, the rate of R0 is extremely high. But I fully agree with Evelyn that the main choice of ESD is not to reduce recurrence, but only to oncologically be radical when you have a clear suspect of cancer. And the problem, as also highlighted by Evelyn, is that the natural history is somewhat against us. So despite the R0 resection rate is extremely high, despite most of these resections are en bloc, because of the natural history, you have a curative resection in less than 50% of the cases. And what we did in a very big international consortium was to look at the fate of those who had a non-curative ESD. So I did an ESD, and then histology came back with a high risk T1. What happened to this patient? Less than half was operated, and the remaining half was not operated based on a multidisciplinary choice. And when we followed those who were not operated, we actually had no malignant recurrence. So even after non-curative ESD, you need to choose wisely between wait and see and surgery. And I also agree with Evelyn that the depth of invasion is not necessarily a major risk factor, and I guess this is confirmed by this series. So what is important for ESGE is that when you have a complex lesion, this complex lesion is treated in an expert center, because expert center can standardize the initial procedure, as Evelyn anticipated. They can somewhat reduce the risk of recurrence, but if there is recurrence that may be extremely difficult to treat, this center have all the possible approach to make it a success in virtually 90% of the cases. So this was my last slide. I don't know, Evelyn, if you have a question. If not, you can launch our terrific guest.
Yeah, so we don't have much time, Cesare, but I think the only point that I think would be good to clarify is the moment that you have to look at the scar, because I think some of the big recurrences are also so big and difficult because the first endoscopy after the piecemeal resection has been so long. Can you say anything about the optimal timing of the second look at the scar?
Yeah, we try to anticipate the second look at the scar. So if the patient comes back with high-grade dysplasia, it is usually in 3 months. If the patient comes back with a low-grade dysplasia, it may be 6 or even 12 months. I don't know, Doug, if you do it 3 or 6 months.
Well, we usually do 6 months for lesions that are over 30 millimeters. Actually, some of the things that are in the under 30 millimeters now, the recurrence rate is so low that we even wait a year. And pretty much all of the large serrated lesions, I think individual serrated lesions are probably not as risky as large adenomas. I think the reason they contribute more to interval cancer is because they're missed more, but I think individual ones are not that dangerous. So, but I agree, I think it's important to remember that most recurrences are very, very tiny, and they're very easily dealt with if the follow-up is at the right time. And I think that's the point Evelyn is making. These huge recurrences, like you were showing, Cesare, are often when somebody has disappeared from follow-up for a couple of years and the lesion has grown back to be as big as it was originally.
Yeah, I think very clear. Thank you so much. So thanks a lot, Cesare. This was a really nice presentation. I think we should hurry up because of the time that Doug should spend with us, because he has so many nice videos. So it's a pleasure to introduce him, Doug Rex from Indiana University School of Medicine in Indianapolis in the US. So please, Doug.
Thank you, Evelyn and Cesare. It's a pleasure to be with all of you. The time is short, so I am going to modify things a little bit to focus on just a few key points. And I want to show you a few videos using EverLift, this injection agent that we have available in the US. So we inject, of course, in conventional EMR. Underwater EMR is another option in which we don't need to inject at all. When we go underwater, we take the gas out of the lumen and fill the lumen with water. Then we don't inject, and we don't need to, because the mucosa and the lesion float up into the water column. And in controlled trials, the main advantage of this has been that a higher percentage of lesions can be removed en bloc. And of course, there's less plastic waste. I think there are other arguments for doing this. I will admit that I still do an awful lot of conventional inject and resect EMR, but I think when you have a lesion in the 20 or 30 millimeter size range that has some of the features Evelyn talked about that make you want to do an en bloc resection, that you're more likely to get it going underwater than you are with conventional EMR, because we make things bigger when we inject them. So why do we inject? Part of this is for safety, to separate the lesion from the muscle. and to delineate the lesion of the border. And then very importantly, the staining of the submucosa by the contrast agent allows us to identify muscle injury. And so with serrated lesions now, we have a lot of evidence that we can remove these without electrocautery. And this is a group of lesions that I don't know that we really need to inject. We don't have a randomized controlled trial comparing cold EMR, meaning inject and resect, to just cold piecemeal without injection. One advantage of injection is it gives you a very clear picture of the border of the lesion. But the other alternative is to just go at it with a snare. And we've seen large observational series with both of these techniques, and both of them have been associated with low recurrence rates. And even when we are not injecting, we can use the water jet in the non-injection method over here on the right and expand the submucosa with that. So again, I think both of these techniques are probably good. The technique on the right is faster. I imagine we'll see a randomized controlled trial, but I would say that cold injection is now reasonably well established from observational studies for the whole spectrum, including lesions of any size in the serrated class. So staining of the submucosa. So the reason again that this is important is that it allows us to see the muscle. So here's a big EMR, and much of the defect is nice and blue. That's all submucosa. Right here, you can see these white bands. That's the circular muscle. So there's a thin layer of submucosa over it, and we've exposed that muscle. We haven't really injured it. We don't really need to close this, but that's what the circular muscle looks like when we expose it. In my experience, the bigger the snares you use, the more likely you are to expose it. What we would prefer to not do is to cut it. So if we just expose it, that's a type 1 muscle injury in Michael Burke's classification. Type 2 means you sort of can't tell, usually because of fibrosis. And then type 3, you've cut it. And the contrast in the submucosa, staining it that blue color, allows us to differentiate the submucosa from the cut muscle, because cut muscle, it's white in color, as you were seeing in the previous video where we were looking at the surface of it. And when you see these thick white bands in the base of the defect, that's cut muscle. You see a lot of thin little white strands that are in the submucosa, but you don't want to see thick white bands. And here's the specimen in the colon and out on the table. And that white on the bottom of the specimen is the cut muscle. So we have to recognize that kind of injury, the type 3 muscle injury, and repair it, or we're going to have a delayed perforation. With our modern methods of inspection, here again is a type 3 muscle injury. We almost never see delayed perforations anymore because we can identify muscle injuries and repair them before the patient goes home. In terms of what we know about lifting agents, we don't have a lot in the way of randomized controlled trials. Succinylated gelatin has been shown to be superior to saline. SIC 8000, which is marketed in the US as Elaview, is superior to saline, and in our study, it was superior to hetastarch. In the US, these agents are approved as devices. So some of the newer agents, O-Rise from Boston Scientific, and then EverLift, these agents have not really been studied in randomized trials. So this is the new agent, EverLift, and it is a cellulose-based agent. It's hypertonic. It has a good lift duration. In general, I think we can expect that these commercial agents are going to create a mound that is larger and firmer and less of a tendency to spread out than does saline. One of the features that I like about it the most is that it's pre-mixed with methylene blue, and it has a pretty deep blue color. I prefer to have a darker blue staining of the submucosa, and it's available in both 5 and 10 ml syringes. I'm watching the clock closely here because I want to leave time for discussion. Just a few words about injection of these agents. We want to inject dynamically. What that means from my perspective is basically that as we perform the injection, we're lifting the needle toward the center of the lumen so that we're sort of shooting the fluid into the upper layers of the submucosa. That's the key aspect, I think, of dynamic injection, is that you're moving the needle, especially moving it toward the center of the lumen, lifting the tissue. And then we want to inject with a strategy. So for a lot of smaller lesions, this is a small adenoma, maybe 20 millimeters. It's best to inject right in the center of the lesion, right through it, so that the lesion ends up on the top of a dome of fluid. Serrated lesions, if we're going to inject those, almost always best to inject through the lesion because they tend to not be enormous. A lot of times I like to inject them on the cecal side, a little bit on the cecal half, in order to tip it toward me. And this approach is generally best for smaller lesions and for serrated lesions. There certainly are a set of lesions where we want to inject on the proximal edge of the lesion. And sometimes that's difficult. I always say you should never overestimate how much polyp tissue can be on the other side of a fold and not visible to you if you can't see the actual edge. And so it can require some special tricks to try to get as close as you can to that proximal edge of the lesion. Sometimes some initial injection will tip the lesion up enough that you can get at it. This is an example of going into retroflexion to do it. I think this is a maneuver that we all should be able to do. Very helpful for lesions that are on the medial wall of the ascending colon near the hepatic flexure. And in this lesion, we're going into retroflexion below it, and then are going to make the injection again on that proximal edge. And the strategy is chosen here because this lesion is sort of draped over a fold and it's hard to access the proximal side of the polyp. In many cases, we don't need to do the resection from the retroflex position if we've injected it well, but we might choose to because sometimes that's easier also. This is a lesion that's down in the cecum. And again, you can see that it doesn't look perhaps like there's a lot of lesion that's on the other side of this little fold down in the cecum. But again, you should never underestimate how much polyp may be over there. So I tried several different tricks, ultimately sort of started injecting at one end of it. And if you get a little bit of a mound of fluid starting to build up and pushing that edge up, then you can follow that initial mound down around the proximal edge, the cecal side edge of the lesion, and be able to inject well. But you'll see here as we do that, as we move from right to left, there's a significant amount of polyp that was hidden. That's kind of useful for us to be exposed. One of the things I get referred from to me from doctors is a partially removed polyp. And it's not uncommon that the part that is on the anal side, on the anal side of a haustral fold has been removed, and the part that was on the proximal side was left in place. So, and then with the much larger lesions, this is a granular lateral spreading lesion that is located in the cecum. The usual strategy is to inject and usually on the anal side, create a mound, resect that, and then move on to the next part of the lesion. I saw one paper from the Netherlands, and we have seen a lot of work in the US showing that lots of benign colon polyps, and this lesion being a granular LST has very little chance of having cancer in it, but they are actually sent to surgery, probably because of concern about complications. And we're trying in the US to make the point with gastroenterologists and other endoscopists that size alone should not be an indication for surgery, because these lesions are typically quite straightforward to remove. To do this relatively safely, we typically use snares of about 15 to 20 millimeters in size. They tend to lift extremely well. We can start at one side and just move progressively over to the other side. But this is a somewhat different injection strategy than we would use for a lesion that's draped over a fold, or the smaller typical 2 to 3 centimeter lesion that we want to inject to perform EMR. Now, if you'll permit me, I'm going to skip over a little bit. I was going to talk a little bit about the modern paradigm of resection, which is to snare everything. And then if we get to the point where we're resisting snaring, to do what we call avulsion, which is to remove the flat tissue that resisted snaring using forceps, either cold forceps or hot forceps. So here's a little nubbin of tissue that resisted snaring. And in the past, we would often take out the argon plasma coagulator and burn that up. But now we don't do that at all anymore to visible polyp. Rather, we avulse it. I tend to use hot avulsion, but you can also do it cold. And so you grab it, put some mechanical tension on it, and then just tap. This is with EndoCut I, low voltage cutting current, and it separates very nicely. And this is not associated with any increase in recurrence. And then Cesare mentioned that the final step, which reduces the recurrence rate, is to go around the margin. First, we carefully inspect the margin for any residual polyp and snare resect that. And then once we've got all the visible polyp on the margin removed, then we take the snare tip, and with soft coagulation current, anytime we're using the snare tip, we should be on soft coagulation current. We burn the entire margin, getting into every nook and cranny. And this reduces the recurrence rate down to the level that is seen with ESD. So it's a very important breakthrough. I'm going to skip over talking about clip closure just for time's sake and show you a few videos with EverLift. So here is EverLift in action. And I mentioned one of the things that I like about EverLift is that it has this really deep blue color that gives nice staining of the submucosa. I mentioned earlier that muscle is white. You do see some thin white strands of submucosal tissue, but this is not exposed muscle. It's not a true target sign. If you have not had the target sign and it's in your future, if you look at a few pictures, once you've seen a target sign or two, you'll recognize it pretty much every time that it occurs. But I really like this deep blue color that stains the submucosa very well. And that's an important goal that we want in our submucosal injection fluid. Here is another lesion that is underneath the ileocecal valve. I'm sorry, I forgot. Sometimes I forget to turn off the AI device when I'm taking off polyps. But again, just to give you a sense of what the submucosa looks like with this fluid, and it again has this really nice dark color, which I think some of the agents that are commercially available in the US have, and some of them don't have, but I think that's a nice feature of it. You can use it for cold resections. I showed earlier an SSL being removed without electrocautery, and I mentioned that really all of the SSLs, unless they, of course, they have some suggestion of cancer, which is quite rare endoscopically. Most of the lesions that we see endoscopically that appear to have cancer in them are adenomas. And in our experience, the rate of cancer in adenomas of a particular size compared to serrated lesions is about 7 times higher. So this is EverLift being used to perform a cold EMR, doing this without epi, so there's a little bit more bleeding that then is going on here than if we are using epinephrine. We can use the water jet very liberally as we're doing this, get very nice delineation of the of the margins of the lesion. You can see the borders out here of the lesion. And so that's a great process, I think. This is a lesion that, as part of a randomized trial, is being removed with cold EMR, and it's a larger adenoma. I would characterize this as a non-granular adenoma with flat elevated morphology. It does not have a pseudodepression in it. If these things lack a pseudodepression, they still have a quite low risk of cancer. You can see here we're getting a nice, fairly concentrated mound of submucosal injection fluid. It's nice and thick. And then we're going to apply, using a dedicated cold snare, we're going to remove this from one side to the other cold. When we start doing cold EMR of adenomas, we are seeing in the literature that the recurrence rate is higher. So that's the downside of cold EMR for large adenomas, is a higher recurrence rate. There are 2 randomized controlled trials that I'm aware of right now going on in the world comparing hot EMR to cold EMR. The advantage of this technique, of course, is that it's almost devoid of complications. So if you're in a practice or an area where you really need to minimize complications, and you have a patient that you're pretty sure is going to come back, and you're good with dealing with recurrences because the recurrence rate is higher, then I think that this sometimes could be the right approach for the patient. You can see how nicely a little bit of residual polyp here and up above are delineated by the submucosal contrast. And then finally, Cesare mentioned tattooing. This was a lesion that had a little bit of a different morphology, so we were removing it by en bloc EMR and then tattooing. This is with spot EX, and this is a more concentrated tattooing fluid, and I usually only put about 0.5 ml or 3/4 ml in. Then I think one of the most important things that we certainly like to see in patients who are referred or for follow-up is that we say in the report where the tattoo is in relationship to the defect. So here I would say the tattoo is just to the right of the defect when the defect is down, or say with the defect down, the tattoo is just to the right. And I'm sorry to skip through some things, but I'm going to give the control of the slides back to you, and hope we have maybe just a minute or two for comments and questions.
Wow. Great videos, Doug. Congratulations.
Thank you.
So Doug, thanks so much. Really nice videos and instructions. So I have one first question, and I see one of the people from the audience has a similar question. Do you miss epinephrine in the lifting solution? Would you ever add it to it, or you don't miss it?
I think epinephrine in the injection solution is nice, especially with a large injection. It keeps the field a bit drier. We have just finished a small randomized controlled trial comparing post-procedural pain and discomfort and nausea in patients who got epinephrine versus not using it. And we found that there's a group of patients who have sort of prolonged post-procedural pain, and that was using 1 to 200,000, especially when you're removing very large lesions and you inject a significant amount of epi. And I presume that's from some ischemia. It typically lasts for an hour or 2, whereas if you don't use epi, most people will wake up with no pain at all, and they can be discharged more quickly. And the occasional patient who has persistent pain for 2 or 3 hours, in our experience, will worry people enough that something is wrong that they'll send the patient down to radiology for a CT scan or something. Whereas if you just wait a little while, it'll go away. So that we've submitted that for publication. It's had some good initial review. I expect it will be published. And again, we only powered it with 20 patients because we thought the effect was clear enough. But I do like epi, and I will admit I still use it sometimes. I do think you can dilute it to as much as 1 in 400,000 or 500,000 and still get a good blanching effect And it does cut down a bit, I think, even on arterial bleeds as well as oozing.
Doug, how do you decide whether to use or not EverLift as compared with saline? What are the characteristics of the lesion that bring you to say, look, this EMR would be with EverLift? And similarly, how do you decide, and this is a question, when to tattoo the defect of an EMR? So what moves you?
Right. So with regard to EverLift, I tend to use it because I like the color with larger lesions, especially adenomas. I think with serrated lesions, almost anything will work extremely well. They like to separate so easily from the submucosa, and using cold techniques, they're quite quick to take off. So I think saline is fine. And with cold techniques, you actually sometimes are a little bit inhibited if the cushion is too firm. You want to be able to push into the cushion a little bit to anchor the snare and really make sure you're cutting through the submucosa. Probably the recurrences with cold snaring are because we don't cut as deeply. And so you want to make sure that you're getting below the muscularis mucosa if you can with that technique. With larger adenomas, I especially like it, and I just prefer the darker color. Tattooing, some people, Michael Burke recently published that he found all the tattoos, I found all the EMR scars without tattoos. And I think if you take a very careful set of photographs, that can help you to find the EMR scars. When you're looking for EMR scars, you generally want to look initially in white light with the colon really well inflated, because that gives you the clearest separation between the white of the scar and the normal surrounding mucosa. I think, we don't need to tattoo in the cecum, or especially if you can take a picture of the lesion and see its relationship to the ileocecal valve, no need to tattoo. I kind of still like tattoos, and part of the reason is that people that are referred to us, they have so much synchronous disease. We take out a lot of additional stuff out of their colon, and I sort of like to know which lesion the referring doctor was actually concerned about. and because sometimes you're not quite sure. They'll describe a lesion and then you find 6, 7 lesions, and I just...
You don't feel obliged to take out all the others, though.
Well, yeah, you know that you have to sooner or later, but you kind of like to be on the same page as to what they were thinking about. And I like to mark them oftentimes for myself too. So if once I get away from the ileocecal valve down to around the rectum, I do tattoo some things. And again, I think it's very important when you do it, to use some careful language that says, where you are with the tattoo in relation to the defect.
Yeah, I totally agree. I think that's very important. So we ran over time already. We have a few more questions, and I think the one that comes back twice is about clipping the post-EMR defect. Do you see any indications? I think that would be the last question to answer.
Yeah, so according to the meta-analyses, lesions that are over 20 millimeters in diameter and have been removed by electrocautery and are proximal to the splenic flexure, that's the group, I think, where there's the clearest benefit. And I try to close those lesions. I think smaller lesions removed with electrocautery where patients are going to be either re-anticoagulated or put on some antiplatelet agent that makes you very uncomfortable. We don't have enough evidence yet to say for sure about those. So that's the group. Some of the ones you want to clip the most, the really huge ones, a lot of times you can't. And so we're either going to need new devices or new approaches to be able to close those.
And never ever for cold snaring, even if the patient is on antithrombotic or the lesion is big. So never ever, or you can have an exception.
I don't close anything that I've removed cold. The only bleeds I've seen really after cold snaring have been in a couple of people who later were found to have coagulopathies, or I have seen it on fractionated heparin, on what we call Lovenox, subcutaneous heparin. That seems to make things bleed. So I have seen a couple of lesions bleed after cold resection, but a cost analysis that was in endoscopy a couple of months ago suggested that cold EMR, has some real cost advantages because of, you don't need to use clipping. And, but I think that you have to be conscious of the risk of recurrence in the current literature when you're using cold resection techniques on larger adenomas.
Yeah, I think you've been very clear on that, and also in saying that that's probably also partly due because of the depth of your resection, right? That's not
right. Exactly.
And on the other hand, when you see a bit cold snaring, a bit more bleeding, that might be another reason, right? So yeah,
during the procedure for sure. Yeah.
So thanks so much for the wonderful presentation you gave us, Doc, but also Cesare. When finishing this webinar that I found very interesting, and I thank you all so much for being present, I would like to remind you about ESGE Days taking place in April in Prague, and we hope you will be present, and not only present but also actively present. So we ask you to submit your great research and abstracts. So as a member, we have several benefits. We have 2 new ones for ESGE, which is My ESGE Tutor, and also we have an ESGE Quality Check app, which might be very useful for you in your daily practice. I would also like to remind you to the next webinar, which has a different time. Be aware, 1 p.m. It's a satellite symposium with Sonoscape on modern EUS, new developments and new options. And lastly, of course, I would like to thank the 2 speakers, Professor Doc Rex and Professor Cesare Hassan, for the great presentations. I would like to thank GI Supply for this wonderful collaboration and support, the ESGE Governing Board, and last but not least, the webinar team from ESGE, David Inker and Gabriela Verga. I hope to see you again soon, hopefully in real life, but this is second best. So I hope you enjoyed tonight, and I hope to see you again. Bye-bye.
Thanks, Evelien. Thanks, Cesare.
Thanks, Evelien. Thanks, Doug. Bye.
Bye-bye.